Good afternoon, everyone, and welcome. Today, I am about to introduce you to Dr. Alexander Feoktistov, and I'm going to tell you a little bit about him first of all before we get going. So, I have his permission to refer to him as Dr. Alex. My Glasgow accent, although I did manage to introduce him correctly. I don't know if I could do that more than one time. So Dr. Alex is the founder and president of the Synergy Integrative Headache Center in Chicago, Illinois. Dr. Alex is board certified in headache medicine by the United Council of Neurological Subspecialties and is a diplomat of the American Board of Pain Medicine, I beg your pardon. He's also board certified in internal medicine. Goodness, I think I might be wearing someone else's teeth today, Dr. Alex. I do apologise. By the American Board of Internal Medicine. Dr. Alex graduated in 1998 with a diploma with the highest honours, summa cum laude. Am I pronouncing that correctly?
Yes.
Thank you. And a Doctor of Medicine degree from Moscow Medical Academy, where he also completed his residency at the Department of Neurology. He is happy to take questions and throughout, but we'll probably do them in little groups as Dr. Alex presents to us. And he's going to present to us for the next 30 minutes on treatment updates. Dr. Alex, over to you. Thank you.
Thank you so much. Thank you guys for joining us. I'm super excited to be here to really discuss with you and hopefully update you on some of the newer cluster headache treatment options. And obviously, because of the limitations in time, we won't be able to cover the entire spectrum of things that are available to treat cluster headaches, but focus on those things that are more or less proven and have a lot of good kind of clinical and scientific standing. So first of all, just a few things that you probably already know, but it's never too much to mention that cluster headaches is one of the most severe pain conditions, not just headache conditions, but pain conditions known to man. It's not the most prevalent headache disorder that we see. It affects about 0.1% of the world population. For example, comparing with migraine headaches, migraine can affect up to 13% of the population. So not as prevalent, but certainly is not less disabling. In fact, it's much, much more severe pain disorder just overall. And unlike migraine, cluster headaches tend to occur more commonly in males than in females with about 4-to-1 ratio. We see it in females nonetheless. And what's interesting that in some of those patients, when cluster headaches occurs in a female person, then sometimes cluster features may not be very classical or very typical, so to speak, and they sometimes may present somewhat atypically in female patients. But certainly it's more of a male headache disorder. And it's a primary headache disorder, meaning that it's not caused by any secondary pathology, such as aneurysms or brain tumors or anything like that. And I'm sure that you're all we're very well aware of the cluster headache presentations and symptoms, but nonetheless, just to refresh that, as I mentioned earlier, cluster headaches is an extremely severe headache, to the point that if you have a patient who is describing their cluster attacks as mild to moderate while being in an active cycle, I would really question that whether this is actually truly a cluster headache, because cluster headache is usually severe or very severe. And it's interesting, whenever we see patients' clinical practice and we ask them to rate the severity or the intensity of the pain, whether it's a migraine or cluster headache or paroxysmal hemicarditis, whatever that is, we usually use that 0 to 10 point scale, at least in my practice here. And patients with migraine would usually describe their headache as being maybe 7, 8, 9. So it's in that severe range. When you ask a cluster headache patient, how would you rate the severity of your pain? Many of them on a 10-point scale, many of them would say it's 15. It's off the chart. There's nothing like cluster in terms of the severity. So cluster headaches are usually severe or very severe. The pain itself, it's relatively short lasting, meaning that it lasts somewhere between 15 minutes and up to 3 hours. And again, contrasting it with migraine typically lasts at least 4 hours. Usually it's a 24-hour deal, but it could be up to 72 hours. And I really would like to run this contrast with migraine in a way as we go through this diagnostic criteria and cluster presentation, because in my experience, many of my cluster patients have been initially misdiagnosed as either sinus headache or migraine headache. So it's really important to understand what are the differences between the two conditions. So the duration of the pain is one thing, the severity of the pain is another, and also the location of the pain. Cluster headaches is known to be strictly unilateral headache. Not only that it's strictly unilateral, it tends not to almost never switch sides. Once in a while, we have patients who experience cluster headache, let's say on left side of their head, and that occurs throughout the entire duration of the cluster cycle. And whenever they enter their next cycle, maybe like a year later, if it's the, let's say, episodic cluster, it can be on the opposite side, but even that is very unusual. So it's typically the same side, the same eye, and it usually doesn't switch sides, certainly not within the same cluster period. Migraine headaches, they tend to switch sides. We expect them to switch sides. So this is really important. So not only that cluster headaches are very locked in its place or into the side, they also a little bit more focal. They're very rarely they would be presenting as the vague, let's say, one-sided headache per se. Usually cluster headaches are much more focused around the orbital area. So they're either retroorbital or periorbital, occasionally spreading into the temple, but it's more of a kind of very focused, painful condition. And always patients should experience at least one of the autonomic symptoms, such as tearing or lacrimation from the painful side eye. Patients may notice conjunctival injection or redness in the painful side eye. Patients may notice nasal congestion or runny nose on the painful side as well. They may notice a little bit of eyelid edema or even ptosis on the painful side. And all of the symptoms, or at least one of those symptoms, should be present. They would last only during duration of an active cluster attack. So 15 to 180 minutes. And once the cluster attack is gone, all of these autonomic symptoms disappear. And because of that prevalence of that nasal congestion, a runny nose, and pain in this area, essentially retroorbitally or periorbitally, many patients are being misdiagnosed with the sinus headaches. I literally just had a patient about maybe 2 months ago who came from the emergency room. He experienced his first cluster attack. Sure enough, went to the emergency room because the pain was just unbearable. By the time he got there, he didn't really feel much pain. So he received a diagnosis of possible sinusitis, prescribed an antibiotic, and sent back home. And then the pain recurred again, and it's been daily for several weeks. And clearly antibiotics did not help him. So it's really important to understand that those are the symptoms that are very common with cluster headaches, and they're only temporary. And another important thing is that, an important symptom rather, is that patients with cluster headaches, they experience a great deal of restlessness and agitation and anxiety when they have, when they're in the middle of that acute cluster attack. Unlike migraine patients, again, who actually prefer to really call it a day and stay in a dark, quiet room, take it easy, lay down, sleep if possible. That's what there would be the migraine patient preference, not with cluster. Cluster patients, they feel quite restless and agitated. And we believe that this is actually not simply a reaction to pain, because we know pain intensity is really off the chart, but this is like an independent symptom that actually it's more of a neurological phenomenon that occurs in addition to severe pain. And usually patients would experience at least one attack every other day or multiple attacks in a day, but usually rarely more than 6 or 8 attacks in a day in a 24-hour period. Another important thing that cluster headaches, they tend to occur in certain patterns or cycles, so to speak, and especially if we're talking about episodic clusters. And they would occur in a certain period of time. Therefore, we call them cluster headaches because they tend to cluster in those cycles, and so on and so forth. If we're talking about the overall classification of cluster headache, there are 2 major groups. There's an episodic cluster, which is probably 80% of all cluster patients. And then there's a chronic cluster headache condition, which is not as prevalent, thankfully, but still occurs. And the difference between them is really whether patients experience any of those prolonged period of remission of cluster attacks. So chronic cluster headaches, they tend to experience cluster attacks regularly and may not have any remission at all, or they may experience remission that is less than 3 months out of a year. So that's a chronic cluster presentation. And obviously episodic clusters, patients could experience cluster attack lasting from just a week or 2 and up to a year, but separated by 3 months of headache freedom. So we talked about the cluster pattern, so to speak, and rhythm to it. So if we're talking about episodic cluster, as you can see on this diagram, so many of the patients with cluster headaches, they experience this bimodal distribution. When we notice a higher activity, higher prevalence of cluster attacks in early spring or maybe late in the fall. So usually that's a bimodal presentation, and that's what we see probably most commonly in patients with episodic cluster when they get 1 or 2 cluster cycles per year, usually during those periods of time, again, spring or fall. Yeah, and I was just talking right before we jumped on this presentation. This year it's been a little bit unusual, at least in my practice. In July, I've actually had about, I think, 5 or 6 brand new patients with brand new cluster onset that just started experiencing headache in the middle of the summer. So, but again, usually that's the pattern that we see with episodic clusters. Chronic clusters, you may still see the pattern that patients experience more severe or maybe more frequent cluster attacks, again, during the early spring and fall. With that being said, patients do not completely break their cluster cycle for 3 months or longer. They continue to experience them pretty much randomly throughout the year, with kind of, again, slight peaks in the fall and spring usually, but not always. We also know that cluster headaches tend to occur in some patients during a certain time during the day or night. And frequently that time would be very, very specific and very consistent. Either it's going to be, so for instance, I had a patient who would wake up in the morning about 2:15, 2:30 almost every night with the severe cluster attack, or it would occur, let's say, a couple of hours after the patient would fall asleep. So there's some circadian and circannual rhythms to it. And because of that, when we talk about cluster pathophysiology, when we're trying to understand what's causing cluster headaches, it is believed that, yes, we know that there's a trigeminal nerve activation, but we believe that actually cluster headaches most likely originate in the hypothalamic region and the result of the hypothalamic sort of dysfunction, if you will. And it has been confirmed on the PET scans when we actually notice increased activity in the hypothalamus during active cluster attacks. And studies have been done that demonstrated certain changes in the hormonal level that are being controlled by the hypothalamic functions, such as prolactin level, for example, melatonin, and so on and so forth. We also noticed on PET scan that there's a thalamic activation during a cluster headache. And we know that, interestingly, that certain regions in the thalamus, actually, some of those neurons, they are so-called the CGRP expressing neurons, and they have direct projections to the structure called amygdala, which is another neurological important brain structure that actually is responsible for our emotional behavior, for our sense of fear and restlessness and anger. And again, those are the symptoms that we frequently observe in patients who experience an acute cluster attack. So we believe this is actually that activation, that thalamic amygdala activation, that perhaps contributing to some of that, change in the behavior. We're also aware of the trigeminal nerve activation, and therefore, cluster headaches are considered to be one of the trigeminal autonomic cephalalgias. So those are the conditions that are involved trigeminal nerve. And we know that if you look at the function of the trigeminal ganglion, most of the neurons in the trigeminal ganglion, they actually express significant amount of that CGRP. CGRP stands for calcitonin gene-related peptide. It's one of the physiological neuropeptide. This is not a neurotransmitter. It's a neuropeptide. And its main physiological function is really dilation of your blood vessels. So that's what the main physiological function is for. Yet we notice that although it's expressed in the trigeminal ganglion, there's 2 different types. We're focusing primarily on the CGRP alpha. That's the one that's prevalent within the central nervous system. We notice that CGRP concentration increases in patients' plasma during an active cluster and migraine attacks, for that matter. Not only just increasing a little bit, it more than doubles actually during the cluster attack, and it happens very rapidly. And that correlates with the migraine and cluster attack severity. If we are treating cluster patients, let's say by administering, let's say, sumatriptan injection, or having patients to inhale 100% oxygen, that does bring the CGRP level concentration down. And that, again, that correlates with the discontinuation or improvement in the pain intensity of the cluster and migraine attack. So we do notice that normalization of those levels. And then there are studies done both, again, in migraine and cluster headaches, that if you take a migraine or a cluster sufferer and infuse them with the actual CGRP, it will bring on a headache in 90% of the patients within an hour. What was interesting, though, in cluster patients, CGRP infusion would bring on cluster headaches in patients with episodic clusters only when they are in that active cluster cycle. Therefore, just keep that thought in mind that we actually discovered that CGRP is really important. It's a very important step or element in the cluster headache pathophysiology, and this is an interesting target for potential treatment. We'll talk about that in a second. And obviously, as a result of the trigeminal nerve activation, we also notice parasympathetic activation using this so-called the trigeminal autonomic reflex pattern. When we have those patients, let's say, so this is TG means trigeminal ganglion. That's this ganglion that releases the CGRP and some of the other neurotransmitters and neuropeptide. But activation of the trigeminal ganglion leads to activation of the superior salivatory nuclei, which is further contributes to the kind of increases the parasympathetic flow through the sphenopalatine ganglion located in the sort of behind the nasal turbinate, that contributes to most of the autonomic symptoms that cluster patients experience, including nasal congestion and tearing and conjunctival injection, and so on and so forth. So parasympathetic system gets also involved and activated during the trigeminal ganglion or trigeminal system activation via this trigeminal autonomic reflex. So knowing the evidence behind, cluster pathophysiology, we certainly can discuss a couple of treatment options. Hopefully it would make sense. And the most evidence we have at this point, if we're talking about acute treatment, so-called level 1 evidence, belongs to sumatriptan injections. So there's several dosages available at this point. Most of the studies that were done in cluster patients, if not all of them, involved 6 milligram formulations. And for that reason, actually, we do use sumatriptan 6 milligrams subcutaneous injections, and patients could use up to 12 milligrams or 2 doses of 6 milligram injection in a 24-hour period. We have tried in clinical practice dosages that are less than 6 milligrams, both 4 and 3 milligrams, and very frequently we still see good results. It is considered to be an off-label use, though. But 6 milligrams sumatriptan is something that we have been using routinely, and it's a standard of care at this point. It works well, it works fast. Most of the time after injecting sumatriptan subcutaneously, you may start noticing plasma concentration of the sumatriptan in the blood literally within a few minutes. And that would correlate with pain relief. Sumatriptan 20 milligram nasal spray has also been shown to be effective as an acute treatment of cluster headaches, as well as zolmitriptan 5 to 10 milligram nasal spray has also shown to be effective in cluster headaches. And the only tablet form that had some evidence that it might be beneficial for patients with cluster is Zomig or zolmitriptan tablet form 10 milligrams. But in general, most of the tablet forms of these medications, they don't really have that quickness to them. And sometimes it may take 40 to 60 minutes for the oral medication to really produce the results, produce pain relief, which is really not an option with most of the cluster patients. As you know, cluster headache may disappear, may discontinue itself without any treatment within 15, 20 or 30 or 45 minutes before even the medication becomes effective. So usually when we talk about acute treatment using pharmacological medications, we're certainly looking for nasal sprays, injectable medications, and so on and so forth. Another really great option that we have for our patients with cluster headache is obviously 100% oxygen. And this is something that we need to keep in mind, that when we talk about oxygen therapy, it should be specifically determined when you're submitting the prescription or an order to the pharmacy or specialty pharmacy that this is for cluster headache treatment. This is not for COPD or anything like this. Patients do need to use a facial mask, usually a non-rebreather mask. They need to have the oxygen flow regulator, allowing very high flow oxygen, up to 15 liters per minute at least, because whenever we use oxygen as an acute treatment, patients are recommended to run the flow at a rate of at least 8 to 12 liters per minute. So it should not be done via nasal cannula. It should be done via the facial, ideally non-rebreather mask, and it should be 100% oxygen. Patients put the mask on at the cluster attack onset and just breathe it for about 10 to 15 minutes. And more often than not, this actual medication can provide significant relief and actual discontinuation of the cluster attack. Other option that have been also used is the intranasal lidocaine. We have had success with using intravenous or intranasal dihydroergotamine, injections or infusions or sprays. They also work. but probably not used as commonly anymore. And now we have another addition. You can see it in the center of your screen. It's when we start to utilize the best of the technology has to offer. We have the state-of-the-art technology called non-invasive vagus nerve stimulation, or so-called gammaCore Sapphire, that has been FDA approved as an acute and prophylactic treatment of patients with cluster headaches. It has also been approved for migraine treatment. And recently, as of literally a couple of weeks ago, it was also approved to treat paroxysmal hemicrania and hemicrania continua. This is a very interesting technology. I'll share some information on that in a minute as well. So it sounds like we have a couple of options that we could utilize for acute therapy, and yet there are certain limitations with those options. So clearly the most common, the most popular option still is the use of the triptans, usually injectable sumatriptan. And the issue with this is that we need to be aware that sumatriptan and all triptans, they are potent vasoconstrictors. So a lot of patients with clusters, they might be in their 60s and 70s. Many of them might be smokers. It has been studied showing that actually 80% of cluster patients are smokers. Some of them may have high cholesterol just because of the age and all of that. So certain triptans, although might be very effective, it's not a suitable option for all the patients, number one. Number two, triptans have only limited use because ideally, again, triptan should not be used to treat more than 2 attacks in a 24-hour period, not even daily, usually 2 to 3 days a week at the most. And yet, statistically, we know that most of the patients with cluster headaches, whenever they're in an active cluster cycle, experience on average 3 cluster attacks per 24-hour period. So again, there are certain limitations. Oxygen seems to be a very user-friendly option. Patients can use it multiple times a day, in fact, to treat all 6-8 attacks if they have this many without really any concerns. Yet, it's not the most convenient medication. You have to have the access to the oxygen tank. And studies have shown that about 70% of patients with cluster headaches respond to oxygen. So there's 30% of the patients who actually don't. So again, keep that in mind when you're prescribing those medications or when you're using those medications, that there are certain limitations, and they're really, really important to keep them in mind. Then there's so-called a bridge therapy. This is sort of like intermediate therapy that connects your acute therapy to a long-term treatment therapy. Usually during that therapy, we prescribe or use corticosteroids such as prednisone or dexamethasone. There's different ways how it could be prescribed, but typically we start patients at a higher dose and then sort of taper it off gradually, either over the course of 5 days or as long as 3 to 4 weeks. All depends on the severity and the duration of the cluster cycle. There have been some studies done showing that dihydroergotamine IV infusion could be beneficial when patients get 1 milligram intravenous dihydroergotamine every 8 hours for 9 or even 15 doses. And that has been shown to be effective as well. Clearly, that requires usually hospitalization, close monitoring, and so on and so forth. Naratriptan has been studied when patients would use 2.5 milligrams every 12 hours for about a week. And that sometimes works as that intermediate bridge therapy. Again, it should not be used more than 7 days in that setting. Certain limitations, again, with that bridge therapy is that frequently after completing that steroid taper, cluster headaches come back. Or after completing that DHE treatment or dihydroergotamine treatment, cluster headaches may come back. Again, keep in mind the comorbidities of those patients, such as hypertension, diabetes, coronary artery disease, that may significantly impact your treatment choices, specifically DHE and the prednisone, again, may not be a good choice for many patients. And also keep in mind that there's a certain drug interactions. For instance, if you are using that dihydroergotamine injections or infusions, during that time, patients cannot use naratriptan, let's say, for breakthrough pain, or they cannot use sumatriptan for breakthrough pain because ergotamine-containing medications and triptans should always be separated by at least 24 hours. So clearly that creates a bit of a concern. If we're talking about prophylactic therapy of cluster headaches, well, up until recently, the standard of care was really about using verapamil, which is a calcium channel blocker. And the usual target dose is 360 milligrams per day. We typically start patients as maybe 180 or 240 milligrams to start with, and then we titrate it up gradually. And you can actually go as high as 720 milligrams. And I've seen even publications when patients were using over 1,000 milligrams of verapamil. In fact, I've heard some experts believe that if a cluster patient does not respond to verapamil, that person is not taking high enough dose, and you keep pushing it. But There's a concern, obviously, because verapamil is the antiarrhythmic medication, so the high doses can produce significant bradycardia and rhythm abnormalities. So once patients get to this high doses, you do want to make sure that you're monitoring EKG at least once in a while. Other common side effects include constipation and hypotension. So something that you want always to keep in mind and remind your patients about this. The data in general that we have to support verapamil use is really, it's better than nothing, I would say, but it's not very strong. It's based on a very small clinical trials, including just a little bit over 30 patients. Another drug that has been used, especially in the past, very commonly, not as commonly probably anymore, is lithium. The usual target dose is 600 to 900 milligrams a day. If you look at all the clinical evidence that we have behind the use of lithium for cluster headache treatment, honestly, there is really no strong convincing evidence to use it actually at all. Studies have done that compared lithium, let's say, to placebo, and there were some studies done showing that there was no advantage, that actually it was not better than the placebo. And there was a head-to-head comparison done once when they compared lithium to verapamil, and lithium was shown to be inferior to verapamil in terms of its efficacy. Nonetheless, some patients respond quite well to lithium. But if that's the case, again, just keep in mind, those potential side effects and toxicity associated with lithium. You do need to monitor plasma levels regularly. You want to make sure that you monitor the kidney function, thyroid function in those patients, and just, keep that in mind all the time. Just to go back to 1 second about the pathophysiology, we talked about that CGRP, or calcitonin gene-related peptide, that is not only elevated during the cluster attacks, but also if you infuse CGRP, it would trigger a cluster attack, especially for those patients who are in an active cluster cycle. As I said, this is such an interesting target. As you know, we've been targeting CGRP in migraine patients as well. And there were some studies done that looked into the efficacy of some of those CGRP monoclonal antibodies to target cluster headache patients. Primarily, so for example, here we're talking about galcanezumab, or Emgality, which is the only CGRP monoclonal antibody that is approved for episodic cluster treatment in adult patients. The dose that we use is a 300 milligram. It's a subcutaneous injection, and it comes with those 3 pre-filled syringes. And each syringe contains 100 milligram of the medication. So whenever patients start their active cluster cycle, that's when they start using this medication. So it's used only during the active cluster cycle. And what this medication does once we inject it, it's a monoclonal antibody that has high affinity and high specificity, and it targets the CGRP ligand itself, or targets specifically that CGRP molecule, not the receptor. It doesn't influence the release of this molecule, but once it's being released, it blocks this molecule and prevents this molecule from activating its own receptor, therefore diminishing the impact of the CGRP on your system. And we are able to see reduction in the cluster attack frequency. CGRP, as I mentioned, is really, really prevalent and is really, really important piece of the migraine pathophysiology. So this is a very interesting target. So this is the result of the randomized double-blind placebo-controlled trial that was done in patients with episodic cluster headaches. And what you're looking at here is this is the reduction in weekly cluster attack frequency over the course of the first 1 to 3 weeks after the very first injection of galcanezumab 300 milligram. At baseline, so before the first injection, patients were experiencing about 17.8, 17.2 cluster attacks per week average. As a result of this treatment, patients who received Emgality 300 milligrams within the first 3 weeks on average noticed about 8.7 weekly headache attack frequency reduction. So those patients actually noticed significant drop in their cluster attack frequency during that very short period of time, comparing to only 5.2 days reduction in placebo. And that difference was statistically significant. If you look at the overall response rate, so those are the patients who noticed at least 50% reduction in their weekly cluster attack frequency at week 3. So again, after the very first injection only. And you can see that up to 71% of the patients who took Emgality or galcanezumab, they noticed at least 50% reduction in their cluster attack frequency, comparing to only 53% of placebo. Again, the difference was once again statistically significant. So therefore, whenever you have, let's say, a patient with episodic cluster headache that you would like to start on the therapy, galcanezumab should be initiated as soon as possible. and patient would administer 3 injections at the beginning of the cluster cycle, and they continue to use it monthly thereafter while in an active cluster cycle. Once they become headache-free, once they reach that remission, they can go off the Emgality at that point and then restart it again at the beginning of the next cycle whenever that happens. Again, Emgality has a very long half-life, so that what allows us to use it so infrequently. It's essentially, it's a monthly subcutaneous injections. It's very shallow injections, usually should be done by patient themselves. So that makes it a lot easier, especially now during the COVID time and whatnot. And now gammaCore, which is the non-invasive vagus nerve stimulation. That's another FDA-approved device. This is non-pharmacological. This is, we're talking about neuromodulation devices that are non-invasive, that is actually approved to treat patients with both episodic and chronic clusters. So overall, vagus nerve stimulation is not particularly a new sort of field. It has been studied over the years, and we know that, for example, invasive vagus nerve stimulation was first approved for refractory epilepsy treatment when patients were implanted with vagus nerve stimulation back in 1997. In 2005, again, invasive vagus nerve stimulation was approved for treatment-resistant depression. In 2017, a non-invasive device, which is the gammaCore, was approved for acute treatment of cluster headaches, 2017. In 2018, it was also approved for acute treatment of migraine patients. In 2019, 2 years ago, it was approved for cluster headache prophylaxis in adult patients. And in 2020, it was approved for migraine prevention as well. Now it has indications for treatment in adolescents as well as of this year. And just a couple of weeks ago, non-invasive vagus nerve stimulation was also approved for paroxysmal hemicrania and hemicrania continuer treatment. It has been very heavily researched and studied. Essentially, it involves the activation of the vagus nerve fibers with this proprietary stimulation that is applied by the patients at the cluster attack onset. And it has actually really very complex mechanism of action. One of the mechanisms is that it reduces the glutamate secretion in the trigeminal nucleus caudalis. It's not only reducing its secretion, but also it can reverse and increase secretion of the glutamate after the stimulation, within usually a couple of hours after the stimulation. It also reducing spontaneous and induced activity within the trigeminal nucleus caudalis, neuronal firing as a result of that stimulation. We believe this is also another important piece of that non-invasive vagus nerve stimulation mechanism, how it works in patients with cluster and migraine headaches. If we look at the data and looking in the placebo-controlled randomized trial, so this is the study that actually looked, it's a meta-analysis result. It looked into outcomes from 2 different randomized placebo-controlled trials, ACT1 and ACT2, and cumulatively looked at the efficacy of the vagus nerve stimulation for patients with episodic clusters. And you can see that this is the 15-minute treatment response of the first attack treated. 39% of the patients noticed reduction of their cluster intensity from, let's say, severe to either mild or extremely mild or no pain at all within 15 minutes. That was observed in 39% of the patients and only 12% of those patients who used just the sham stimulation, a non-therapeutic stimulation. If you look at the impact of vagus nerve stimulation using that non-invasive device on overall weekly cluster attack frequency in a long run, if patient would use the stimulation on a regular basis, then you can see, so this is the interesting study that compared, so the gray line here indicating the so-called the standard of care alone. So patients with cluster headaches were using the standard of care therapy, whether it was verapamil, whether it was something else, so standard of care therapy. At the orange line, you see this is the result from standard of care plus non-invasive vagus nerve stimulation. And as you can see, you see significant reduction. And this line indicating the number of attacks per week. And you see that when you use a combination of non-invasive vagus nerve stimulation with standard of care, you notice significantly better results. And again, the difference was statistically significant comparing with the standard of care. And those patients who initially the first 4 weeks were using just a standard of care were then introduced into this non-invasive neuromodulation device. You notice how their pattern also started to improve, and actually their headache frequency took another significant decrease as a result of the therapy. So if you have a patient who needs to be on a prophylactic therapy, you typically start them on 3 2-minute stimulations in the morning, and they repeat the second stimulation in the evening or at night. Again, 3 2-minute stimulations, literally back to back. It could be done on either side. We usually recommend to do it on the painful side, on the side where patients experience cluster headaches, and do that on a daily basis. For acute therapy, patients could administer, again, 3 2-minute stimulation at the start of the cluster attack. Then they take about 3-minute wait and can repeat the stimulation again on the painful side, just stimulating the neck right inferior to where we feel usually the pulsation of the carotid artery. This is the projection of the vagus nerve, which happens to be located right behind, kind of in the sheath of that carotid artery. That's the target zone that you're trying to stimulate. You apply this device there, and only a few minutes of stimulation could actually bring the severity of the clusters down and actually stop the ongoing cluster attack quite quickly. So to summarize everything that we talked about is that you should be aware and remember that cluster headaches, although they're not very prevalent, it is extremely disabling condition with significant impact on patients' quality of life. And that although we have acute medication option, there are significant limitations. So we need to expand our focus and use everything that we have at our possession. It is strongly recommended to start prophylactic therapy as soon as possible at the beginning of the cluster cycle. Therefore, you need to recognize it quickly, and definitely consider using non-invasive vagus nerve stimulation that has shown to be effective on its own for both the prophylaxis and acute treatment of cluster headaches. And certainly it has been shown to be very beneficial if it would be used as an add-on to another kind of standard of care therapy, whether it's verapamil or topiramate or any of those medications. And with that, I would like to conclude the slide portion of the presentation. And if we have any time for questions, I would be more than happy to answer them. Thank you so much for your attention.
Thank you so much, Dr. Alex. I do have a question which has come in from one of our attendees. And then once you've answered that, I actually have a question for you, from me, if you wouldn't mind. So we've got about 5 minutes or so. We've been able to run a little over, which is great. So we've had a question asking, did the CGRP infusion bring on both a migraine and a cluster in people who had both conditions?
I'm not so if I understand the question correctly, we're looking for those people who are, well, lucky enough to have both migraine and cluster headaches, correct?
Correct.
I'm not aware of actually any studies that were done in that specific population of patients, but independently, absolutely. So the studies were done in patients with migraine, and if you actually infuse CGRP intravenously into patients with migraine, it will bring on a migraine attack in about 90% of the time, 90% of the patients, as early as within an hour. Well, we can't really call it a migraine attack, but it's the migraine but it's a headache episode that actually meets all the migraine criteria. So it's a migraine-like headache within an hour after the infusion of CGRP in migraine patient, and about 10% of the patients might experience a migraine-like headache a little bit later in the day, usually 2 or 3 hours later. The same thing was demonstrated in cluster headache patients, both, by the way, episodic and chronic. The difference was that in episodic cluster headache patients, IV infusion of the CGRP itself was actually bringing on cluster attacks only for those patients who happen to be in an active cluster cycle, not during the remission. And obviously in chronic clusters, it was inducing it pretty much at any time.
Great. I think I have another question. What is your opinion about the greater occipital nerve block or using Botox as a prophylactic
So
therapy?
as far as the greater occipital nerve block, it has been actually studied, and we still use it quite actually routinely, at least in my practice. I do think great occipital nerve blocks have its place. It's a very simple and easy, rather, and safe procedure that could be done very quickly in the office. It takes a fraction of a time. It doesn't really require an extensive, per se, training. People should know how to do it, obviously, but it's very simple and easy procedure, office-based procedure. I even tell my patients with cluster headaches sometimes if they're in an active cluster cycle and we need to do something like this, because it takes literally a couple of minutes, I could get them into my schedule, even if I'm completely booked. And I know my patients aware of that we can get them in and do it. Studies have been done that looked into that, and it had shown to be beneficial in patients with cluster headaches. More so, as an extension of that, some studies were done that looked into the occipital nerve stimulation. So I know during my fellowship years at Cleveland Clinic, there was a study done shortly before then when occipital nerve stimulation was applied to treat patients with cluster headaches with great results. It's still not considered to be standard of care or FDA-approved intervention, but it has been used in clinical practice with some good results. As far as Botox, again, no really strong placebo-controlled randomized trials done that would show clear benefit of Botox therapy in cluster headaches. So the data that we have right now to support its use in cluster patients is very, very limited. So it's not indicated at this point.
Great. Thank you so much. My question would, because we have gone a little bit over, my question can wait till we, perhaps if you are joining us later at the question and answer session, I can ask you that then. For the meantime, Dr. Alex, thank you so much for a very informative presentation. It's lovely to see you again. And thank you for joining us and for giving us your expertise today. We very much appreciate it. Thank you very much. I'm going to close the session now, and I hope to catch up with you later. Thanks everyone for joining.
Thank you.
Bye-bye.
Bye-bye.